Hello, everybody, and thank you for joining today's webinar, What Telehealth and Video Chat Means for Substance Abuse and Mental Health Providers, brought to you by One Touch Video Chat and the nonprofit Humans Helping Humans. I want to go over some quick housekeeping items today and talk about the agenda for the webinar. First, this webinar is being recorded, and the recording will be provided next week to those in attendance. At the end of the recording, we're going to provide several handouts that we'll use today throughout the presentation. There's a new infographic on youth mental health, as well as an infographic on the opioid epidemic, and 2 ebooks on innovation in mental health, as well as substance abuse. Today's agenda, we're going to talk first about mental health, talk about some important facts and stats, talk about the rise in shortage areas in rural communities, talk about the current traditional model of how mental health works today, and then a new innovative model incorporating creative and innovative technology. We're going to talk about video telehealth and new billable codes coming in mental health and what's billable today, as well as video counseling opportunities in key areas to grow and expand business and support rural demographics and other demographics. And then we're going to transition and talk about substance abuse, as mental health and substance abuse go hand in hand. We're going to first talk about the opioid crisis, some eye-opening facts from an infographic that we put together, as well as relapse rates, how to impact it and change and save lives. And again, talk about the traditional substance abuse and addiction treatment model, and then the new innovative model highlighting video crisis hotlines, video admissions, and video counseling ongoing pre and post rehab. And then we're going to talk about the impact areas, the numbers on readmission and relapse rates, and then really how does video chat and video telehealth work. And then we're going to take questions throughout the webinar and discuss those at end and provide you the handout. So we're going to start today talking about mental health, the rise in mental health and the barriers to mental health treatment. So currently today, over 40 million Americans, 1 in 5 Americans have a mental health condition, but only 56% are not receiving treatment today. So only 44% are actually receiving treatment. There's some big barriers to receiving mental health treatment. The first one I want to talk about is really the culture, access, and knowledge. So in some cultures, mental health is not discussed. It's not discussed with youth. It's not culturally accepted to receive mental health treatment. And so there's a lot of knowledge and really, community involvement that needs to happen around making it acceptable to seek treatment. In some areas, there's very long wait times, and we're going to talk about some of those shortage areas. And so it's not instant to get mental health treatment, which is why you've seen some rise in suicide and rise in hospital admissions. And then convenience and availability. We live in a world where we have access to almost anything, and especially with your millennials and Gen Zs, they want to be able to get an appointment instantly and not wait weeks. When you're talking about general health care, the rise in clinics and 24/7 have increased dramatically just because that demographic doesn't want to wait for a doctor's appointment and doesn't even have a primary care physician. And then mental health has the highest no-show rate and readmission rates of any other practice area. And we're going to talk about a little bit about why. So you've probably heard, if you've read anything of any headlines about the increase in shortage of psychiatrists and psychologists, and how rural areas have such a low psychiatrist to patient ratio. 60% of all counties in the U.S. and 80% of rural counties do not have access to even a single psychiatrist. And most psychiatrists right now, a large percentage, over 60%, are over the age of 55, which is really fueling retirement shortage. And the number of folks going to school today cannot keep up with the demand of retirement. So some of the shortages that we're seeing today are only going to get worse as those numbers continue to increase. The reason we're talking today about mental health and substance abuse in one webinar is that nearly 50% of mental health patients have a substance abuse disorder. They really go hand in hand in a lot of cases, and especially when we're talking about youth. So talking about youth and mental illness, I want to just really go over some eye-opening stats. First, 1.7 million youth have major depression and don't receive treatment. Now, if you think about 1.7, what does that really mean? If you just close your eyes for a second and think about 17 college football stadiums filled with youth, that's the equivalent of how many youth right now are going through depression. 6 out of 10 teens have depression and are not currently seeking treatment. And 8 out of 10 teens with anxiety do not receive treatment. A lot of that leads to substance abuse to numb some of that pain that they're having and not knowing how to deal with it. On the suicide side, suicide is the third leading cause of death in youth ages 10 to 24. So really getting to youth and trying to treat that mental illness and treat that at a young age really leads to what we see in adults, because 50% of mental illness begin before the age of 14 and 75% before the age of 24. So if we can impact it at a younger rate, a younger age, it can really help out over the course. When we talk about access to care and we talk about not waiting for appointments, a lot is driving the mental health and actually in hospitals and the readmission rate there. Over 40% of hospitalizations for mental disorders are readmissions, and hospital staff will tell you that they're seeing the same patients over and over because they can't get access to care. That's costing the U.S. over $6 billion in hospital costs for suicide reattempts. 50% of those are readmissions. So once you go into the hospital, the risk of suicide is 100 times greater during that first week of discharge. So there's really a need to get that mental health plan and that continuum of care before somebody leaves the hospital, and making sure that they have all the tools and resources to reduce that readmission, or even worse, for them to actually commit suicide. When we look at mental health issues, they've increased significantly in what's being seen in ER, 42% over the last few years. And of emergency hospitals, physicians that are saying, do they have a psychiatrist on call? It's less than 17%. So, we really need to address, how to virtualize some of this hospital readmission and that continuum of care once they leave. So I mentioned earlier that mental health had the highest no-show appointment rate of any other practice area. That's really costing the healthcare providers over $150 billion per year in no-shows, and the no-show rate is 35%. Now, when we look at the patient experience, we look at the convenience factor, the no-shows are really driving missed appointments in a couple of key areas. Number one, a lot of the Medicaid appointments and even insurance appointments, there's a lack of transportation. And when you're talking about in some of these rural areas, you could be driving 30, 45 minutes to an appointment. And when you think about the time it takes just in transit plus the appointment time, folks are having to get off work for a half a day just to make their appointment. And if you're looking at someone that's coming in on a weekly basis, most people don't have the financial capabilities to be able to take off that time. Too much time between appointments. For those folks that can't make a weekly appointment and maybe they're going once or twice a month, there's so much that happens in life. There's so much that comes up that if something happens in between these appointments, they're typically going to a hospital or seeking other forms of treatment. When you look over here, the numbers are really much higher when you're talking about school-age children. So when we're talking about the rise in use of mental health, I was at a conference a few weeks ago, and one of the mental health professionals said, the youth is a big issue because it's, a double whammy. A parent has to take off work to take the child to the appointment, and then the child has to get out of school, which is costing the government and school money. And when you look at the time it takes for the parent to get off of work, it's really costing both sides. And so the no-show rate on the youth mental health is significantly higher because parents have to take off work and the child's missing school. And so when that weighs together, we really need to think about how to make that more convenient and more frequent to really beat the convenience factor and the patient satisfaction. 72% of people under 44 are willing to receive their mental health appointment virtually in place of that in-office visit. So not to say that every appointment should be virtual, but it really should be down to patient preference as well as providing that convenience factor. So when we're talking about key shortage areas, it's really all over the U.S. 123 million people, that's 40% of the United States, live in a health shortage area. There's only 590 psychiatrists that serve over 27 million Americans in these shortage areas. In some counties that we're going to talk about here, in some states, the ratio is really 1 to 100,000 people, 1 to 500,000 people in some areas. These are the top areas here that have less than 25% of the needs being met for mental health. So if you're a mental health provider, you're licensed in these states, or you're in a neighboring state, we're going to talk about some ways to really help out and provide virtual mental health in these areas. Because there's such a rising demand to be able to support it without having to move or relocate. So today, here's a high-level kind of life cycle of mental health in a few different buckets here. So I want to talk a little bit about how the model is today, and then some innovative ways of the kind of the future model. So today, there's education in the community, whether it's in schools, whether it's in employee EAP programs, clinics, doctors' offices, on really mental health and educating what does that mean and who to contact if you're having issues. And there needs to be, some emphasis that's really not done at a cultural level. That's really just done kind of at a either education or community level. And then on the crisis side, there's a lot of 1-800 numbers, there's TV commercials of hotlines, there's doctor referrals, clinics. If you're in a substance abuse treatment center, there's referrals from there. And that's really, kind of the two main buckets of, if you're needing help. And then there's the seeking and treating portion. This is really, if you have insurance or if you have Medicaid or Medicare, you're trying to find online who takes, those types of patients or that type of insurance. There's a bunch of different websites, or maybe your health provider tells you who's covered. And then the model's really broken from there. You're calling an office, typically, a mental health provider. If they're in session, you're getting an answering machine or a receptionist, you're leaving a message, you're filling out a form online. And there's this back and forth that, in some areas could take days, could take weeks just to find out if that person is taking new patients or when you're able to get in. And that's a very critical time to be, talking to somebody depending upon their situation. And then once you get into treatment, there's that ongoing support. There's the therapy appointments, the psychiatry or psychology appointments. There's some support groups, potentially locally, depending upon your what you're seeking treatment for. There's maybe some social media or some apps that you can be a part of, just in general. Now let's talk a little bit about kind of the future model. So if we're looking at the community and the education part, really establishing relationships within community organizations, being able to digitally and mobilely connect people to video crisis hotlines. If you look at the demographic of Gen Zs and millennials, calling a 1-800 number is not is kind of old school for that demographic. They see it as something their mom or dad might do. They're more into digital means. They're a FaceTime video calling demographic. If you look at even parents and grandparents who are now, video and FaceTiming with their kids and grandkids, it's kind of gone across all demographic, but Gen Zs are a video first calling demographic over audio. And so to be able to have video crisis hotlines where you can see another human on the other side of the phone, hear what's going on with them, even if it's a peer-to-peer crisis as kind of a tier 1. So we talk here about the crisis hotlines. Today, you're talking to somebody that you don't know, if they are going through the same situation or a similar situation, or who's even on the other end. There's no face, there's no name. And really getting back to that kind of human-to-human connection to really impact and save lives is putting a video crisis hotline or a video line in place and having kind of a tier 1, tier 2 model, some peer-to-peer support group, as well as having mental health professionals on those video lines. And then really escalating that if needed to a hospital or a psychiatrist, whatever it may need to be from a video routing standpoint. And then once you have a person that's in treatment and either working with you as a provider or working with your treatment facility, being able to provide video counseling and video support to urban areas and rural areas. So maybe you live in, a big city, but you've got some rural shortage areas that are 45 minutes away from you that you could video counseling and provide support to patients there. Video peer-to-peer counseling. So do you have, are you a member of groups that can provide peer-to-peer counseling? So if your patient's in between appointments and they want to talk to somebody else about what's going on, and that can really help them in between appointments. And then from a psychology or psychiatry standpoint, being able to, not every appointment, but being able to do appointments through video telehealth and really allowing that patient to have their preference of how they would like to communicate, what the convenience factor is, talking to mom and dad if it's youth, and maybe they can get off work once a month to come in person, but not every week. And then really working with your school systems and providing video telehealth into the school systems and really making that an offer with parent consent or with counselors there. And then really looking at the ongoing, and then the value of care. Your patients will stay with you longer if they're demanding the convenience, and they're going to be demanding the communication preference, to really be able to provide that technology to them and allow them to engage, schedule appointments, get help on demand. Maybe you team up and provide crisis from that standpoint. All right. And then some operational use cases from that standpoint. New patients. So you're going to be able to reach a new demographic on being able to do mental health virtually. And so the ability to increase conversion rates and schedule more consults, you're going to be more productive. You're going to be able to do more appointments, less drive time for yourself as well as for your patients. Video crisis. So if you're able to support school districts, universities, employers, a lot of mental health professionals are providing video on call for employees. Employers in their area, as well as assisted living for the behavioral side, and underserved communities and hospitals. So some rural hospitals don't have mental health professionals on staff, and being able to be on video staff and have another doctor be able to conference you in is a nice opportunity to expand if you're looking to expand your business from a geographical reach standpoint. And then reduce no-shows. If you look at what your no-show rate is today, if you're above or below the industry standard, how much are those no-shows costing your practice and your facility, and how to really reduce that. Practice areas. So there's a lot of billable codes today for mental health, for video telehealth, both on the counseling side and psychotherapy and CBT, individual. And then there's a bunch of federal laws that are coming down January 1 that will allow additional mental health billings in almost all states. And so you definitely want to be aware of what's coming in January and what can be billed today. If you have questions on that, we're happy to answer those for you. And there's new codes that are coming for substance abuse and mental health and intervention and ongoing support for substance abuse on the mental side. And so if you're not providing that today, those are some areas that you might want to look at from that standpoint. We're going to transition over to talking about substance abuse. There is a Q&A portion in the webinar. If you have any questions, feel free to submit those. We'll answer those at the end. If you had any on mental health, feel free to submit those. And as we're going through substance abuse, if you have any questions on that, feel free to submit those as well. So everybody knows, about the opioid epidemic and really what a crisis we are in the U.S. Some of these numbers and facts and figures are very eye-opening. You might know some of these, but Americans represent 99.7% of the hydrocodone consumption in the U.S. And so really, when we look at the opioid epidemic, globally, it's definitely a problem, but the U.S. it's a much higher problem. The opioid addiction cost over $504 billion, the government, in 2015. 197 people die every day from an opioid overdose. That's more than highway deaths. And looking at people that have an opioid disorder, 2.6 to 5 million, depending upon if you're going off the CDC numbers or depending upon what numbers you believe. But less than 10% of people are seeking treatment. It's driven a big surge in heroin and fentanyl usage. 80% of heroin users started with prescription opioids. If you look at the numbers of addiction, a lot of it stems from numbing the pain from mental health issues. And that's why this really goes hand in hand. The opioid epidemic, a little bit more, 40% of opioid overdoses started with prescription opioids. We've done several podcasts on the opioid epidemic and Purdue Pharma and how the U.S. got where they were there. And there's links on our website, but we really break that down. But the heroin usage and heroin ODs has risen over 500% between 2002 and 2016. And the overdoses from opioids have gone up 66%. And so the big thing about the opioid epidemic is the rise has been in males over the age of 45, in demographics that we've never seen before that have had addiction. It's not about the color of skin. It's not about race. It's not about, economic income. The prescription drugs that have been given that Purdue Pharma said were non-addictive, were addictive. And now that there's constraints on pain management, this has gotten people to go to more, heroin and fentanyl and get it cheaper, and has driven a significant impact from that standpoint. There's really a need for continued care to help make an impact on relapse rates. And so there's a big importance of having quick intervention for relapse rates. For opioid addiction, 90% relapse rate and 64% relapse rate within the first week. And so we're going to talk a little bit about the traditional model, substance abuse and addiction model today, and how to really help with that relapse rate. 2/3 of folks that are in recovery relapse within weeks to months. And on the alcohol side, 90% within the first 4 years. And so how do we really, impact this and really impact and save lives? So today's model is broken in several areas and can really use some creative and innovative ways. And so really, again, on the community side, really getting into the community on how to, identify addiction and how to really understand that it is a disease, and take out the misconceived notions of, the epidemics and addiction. Really to look at innovating hotlines. And so when we look at demographics that won't call 800 numbers, when we look at folks that are really trying to reach out to somebody on the other side, and we're looking at kind of that first line of defense, we're looking at, how the typical model works of scheduling a phone appointment in a call center and then taking it to an admission person for treatment. Really looking at trying to get a higher conversion rate of people that are actually calling in and taking that first step, whether it's a family member, whether it's the person that needs help themselves, and really taking that to video, and really getting them, a face-to-face, a human-to-human, to really impact that. So today, when you look at the hotlines that are traditional, when you look at a traditional treatment program that's an inpatient, a 30, 60, 90-day treatment program, obviously in those treatment programs today, there's a lot of tools for AA or NA once you get out. But the reason inpatient treatment programs are so successful is that mental health component, that component that's getting to the issues of why there's an addiction problem and how to really, establish the skills to cope with that once you leave treatment. The big disconnect is, once you leave treatment, putting it on the shoulders of the person that was seeking treatment to then now go wait for a counseling appointment and get back into an environment. And so there's going to be a great opportunity for substance abuse facilities to really continue that relationship post-treatment. With the technology and the billable codes, there should be no reason why that substance abuse and treatment facility shouldn't be able to continue the treatment and help further post that 30, 60, or 90-day treatment. So there's a couple of ways, buckets here. Number one, video crisis hotlines. So getting more involved out of the phone and the call centers from TV commercials and online and so forth, and moving that to video, moving that to kind of tier 1 and tier 2 where the tier one can be more from the admissions process, and tier two can be more getting an actual counselor or doctor as needed on that video consultation. Really identifying and training your folks to read mannerisms and read emotions, just like you would do if somebody was sitting in front of you of, are they currently on drugs? Are you in an OD situation, and how to escalate that? And then once you actually get them into a treatment facility, then, part of that process of the counseling and those sessions are having family participate. And again, back to the mental health that we talked about earlier, is you're taking off work, family can't come to, every appointment. So allowing, and you may not even be in treatment in the same city in which your family lives. So having more engagement, having more involvement with that family really will help with, that success rate. And so being able to video them in for counseling. When you're identifying a sponsor before somebody gets out of treatment, being able to establish that sponsor relationship while they're in treatment and having those video connections. And then most treatment facilities don't have, they have some mental health providers on staff, or maybe counselors on staff, but maybe not a psychologist or a psychiatrist. And so being able to video those in. There'll be new billable codes in January for provider to provider that will cover that and allow not only mental health professionals to work with more substance abuse facilities, but how more substance abuse facilities be able to extend that mental health beyond the treatment. And then in some areas, substance abuse facilities have very long wait times out in rural areas. And so how do you, start that relationship through video and get them connected to video support groups and, video crisis lines and things like that, and continue that relationship even before admission on getting them to come to treatment. The no-show rate being very high of calling and talking to an admissions person and then actually showing up for day one, you can reduce a lot of that with that ease of talking to family members and talking to the person on video and letting them see that there's another human on the other line and that you've been in their shoes and you've walked that mile prior to them showing up. And then once they get out of treatment, really establishing that video counseling ongoing. So if you have the counselors on staff, or if you are extending that with the new billable codes, if they've been, seeing Sally 3 times a week while they were in treatment, can they continue to see Sally once a week and get that in the schedule, or, somebody else? And so there's never a lapse of counseling. There's never a lapse of mental health. There's accountability in doing that through video. They can do it before work, after work, lunch breaks, whatever it may be, to continue that support. And then connecting them with, whether it's, alumni, whether it's people that have, whether it's sponsors, to be able to hit a button and instantly, whether it's 12 o'clock at night or 4 a.m, have people on your video crisis line to be able to really talk to somebody when they're in a time of need, human to human, face to face, and prevent them from relapsing. So as we just talked about, kind of the big buckets of innovation that can really help reduce relapse. On the video admission side, that can really help for higher admission rates, having that emotional face-to-face connection, reaching that younger demographic that's not going to call a 1-800 number, reaching those family members that have never had addiction in their family before and don't know where to turn to, and walking them through, hand-holding them through that process. Peer and sponsor support. So being able to have that instant video connection, a broader reach, much more scalable, much more accountability, and doing it this way, you'll be able to reach more people faster. extending that video counseling more frequent, reduce the no-show rate, reduce relapse rates, and really engaging that family participation is critical during both before and after treatment. So the key benefits and how it's going to impact your numbers. Number one, the increased value of care and the continuum of care. So really, if you have a substance abuse facility and, you're being asked how you're different than the others in your area, this is obviously a competitive advantage. It will definitely help with your numbers and not only just the treatment that you're talking about today, but the continuum of care once they leave. Really decreasing that relapse rate. So establishing those relationships, continuing those relationships post-facility, and really adding that to the toolkit of once they leave the treatment facility. So when you look at those tools from, if you're being paid by insurance or Medicaid or Medicare, really having those tools will really increase those numbers. And then really joining a peer-to-peer community that offers video support, really educating, connecting people together, whether you're creating your own community or you're joining a video community, creating those emotional connections. There's nothing that beats face-to-face if you're in person, but the next best thing is video face-to-face and really putting a face to the story, really talking human to human. Nothing replaces human to human. And so seeing somebody on the other end, seeing what they're going through, letting them know that you've been in their shoes really helps throughout the entire journey of both the mental health and the substance abuse side. And then the convenience factor. So, everybody has the best intentions when they're coming out of any type of treatment program. You get back into the real world, you've missed work, you have to go back to work, or you're looking for a job, whatever it may be, you've got family. And convenience is just a big issue. And when you start seeing, when patients start seeing signs that they might relapse, they need to be able to reach out and really establish that connection and what to do. So we've talked a lot about the creativity and the video side. I'm going to show you a little bit how it works. So if you're a mental health provider or a substance abuse treatment center, you have your website. The video goes directly on your website. It's a little, just like you'd have a text chat, it's a video chat that goes. There's no downloads that the patient or the person seeking treatment or provider, it goes right on your website. It takes about 3 minutes to add it. And then with a clickable button, you can video right off of the website. A couple ways that are kind of cool. You have video skill-based routing, so you can ask for the reason to connect. So it could be, let's say, admissions. It could be that you want to find out information about treatment. It could be that you need to connect with a counselor and you're a past patient or a video crisis. And then based on that, the technology platform routes it to the appropriate individuals, and your healthcare providers, your counselors, your admissions folks log into this dashboard. Again, it's browser-based. All you need is browser and a webcam camera, and you're good to go. Doesn't matter if you're at home, in the office, wherever you are. And then based on the routing, so if Emily and I were in the admissions department and we talked to folks that are seeking treatment, anything that was on the website that was clicked admissions would go into our queue. We'd get a notification that there was a video there. And if Daniel and John were on the crisis line because they're counselors and, past patients and current ones come in, then they would get notifications and they would take those calls. Very similar to how you would have a phone hotline today or your phone admissions, and very similar, but with video. And then at the end, there's an opportunity for survey information on the patient or seeker side, as well as the professional side. And this is typically about their experience, not personal information about their experience and would they use it again and was it useful kind of thing. So here's a look, and this is what I was talking about, the reason and the direct dial. The direct dial is really good for scheduled appointments. So if I was a counselor, Emily and I had an appointment today at 3:00, I would have her go directly to our substance abuse website. I would send her an invitation or let her know what my direct provider code was. She would enter that. It would come directly to me, just like if she was sitting in the lobby, she would be waiting and I would grab that, and that way she would come with me. So she wouldn't have to download any third-party applications, and we would have a direct connection. So here, the other great thing about this, or about the technology, is it will show you from a reporting standpoint what types of video calls you have coming in, how many crisis calls you have, how many admission calls you have. And then from a billing standpoint, if you're billing the telehealth appointments on the mental side, or you're billing psychiatry or psychology, you have to have record of it. And so you'll have which doctor, which provider, or which counselor took it, what the duration of the video was, and all the respective reporting that you would need from that standpoint. In addition, there's graphical reporting and things of that nature. You get to manage it all yourself. You can, add and delete users and put them in groups instantly. If you're providing mental health, let's say for a school or an employer, and you see a surge in calls or long wait times, you can go add other mental health providers into those particular groups from that standpoint. So I'm going to open it up for questions. If you have any questions, there's a Q&A portion. It should be out to the right of the webinar. You can submit any questions. We will answer those. And if for some reason we can't get to them, we will get back to you. Emily's going to push the handouts that we're going to be giving out today here in a minute or two. And you're feel free to download any of those, all of those, whatever you need. And the recording to this webinar will be provided in the next week. So the first question is, how long does it take to incorporate a solution like this for video into a substance abuse process? Typically, it's a very short implementation time because there's no hardware or software or anything that you're hosting. And so a lot of folks haven't done this in the past because it's been expensive from a hardware and software standpoint. But typically, we can have you up and running within 48 hours, start to finish. The only thing that's required technically on your side is if you want to put it on your website. It takes about 3 minutes to put it on your website. You can put it on one page or all pages or anything, or we do landing pages from that standpoint. So it's pretty quick and easy process to instantly see feedback. The next question is, what is the ROI? How expensive is it in relation to how much you can bill for appointments? It depends on which type of appointments you're billing, but it's very cost effective in that it's for most either substance abuse, or I'll take mental health first. For most mental health providers, you'll be break even with about three appointments per month. And then anything over that would be profitable from that standpoint. Most folks are doing more than that in, a week, or, some folks have gone 90% virtual from that standpoint. Substance abuse, the ROI is significantly greater given, you're getting someone from a treatment standpoint. So it depends on how you want to look at the ROI from the substance abuse. If you're looking at it from admission rate, if you're looking at it from, continuum of care of counseling, but the ROI is typically within days from that standpoint. The next question is, how difficult would it be to train our staff? So typically your staff is logging into the portal. We have online training as well as walk through that. I would say typically, because it's so simple and intuitive, on average, typically a 15-minute session and your staff would be good to go from a training perspective. The administrator, whoever would be the administrator for the technology, it's typically about a 30-minute training session. So typically, get the folks on and do a training session from that standpoint. We're going to push the handouts, and if my contact information is on this page, if you have any additional questions, if you have any additional thoughts, feel free to send an email. Oh, sorry. One more question. Can the video chat be set up for certain hours? Yes. So at the start of the implementation, you establish what hours you want, what days a week and what hours you want the video chat to be available. And if anybody accesses the video chat outside those hours, they would get a message that video chat is currently not available. And most clients will put either if they have a 24/7 line or any disclosures, you would put it on there. If there was an 800 number that was 24/7 or after hours, or a typical, if it's mental health, they need to call 911 or whatever it may be. But yes, that's all configured in the system for that to be available from that standpoint. And then we're going to push did you push the handouts? All right, everybody should have the handouts. If there's any additional questions, feel free. And the last question, and I can send you some information on the person that's asking the final question on pricing. We do not charge per transaction. We do not charge per minute. We do not charge per call time. It's based on the number of users, not the number of patients. So the number of users from your standpoint. So if you add, I don't know what type of company, but if it's, you add a few counselors, an admissions person, whatever, we're charging on unique users to the actual platform standpoint. And if you want to get more detailed questions on pricing, feel free to shoot me an email and I can get the pricing over to you. Want to thank everybody for joining today. Going to give you a few minutes back to your schedule, which I know everybody loves. Hopefully you enjoy the handouts that Emily just pushed out to you. Some great infographics from that standpoint. If you have any questions on any of the infographics or ebooks, our contact information is on there. And want to thank you for joining the One Touch Video Chat and Humans Helping Humans co-branded webinar today. Have a great afternoon.